It's a paper cut, barely half an inch. You barely feel it happen. You're refilling a chart at the nurse's station and the edge of a folder slices the pad of your finger. You laugh it off. You've had worse from your own kitchen knife. You press a tissue to it for a few seconds and go back to work. That's it. That's the whole story, as far as you know. But you're standing in a hospital, and hospitals are full of things that a kitchen never is. Bacteria that have survived antiseptic soap, bacteria that have already outlasted antibiotics on other patients down the hall. One of them just found a doorway into your bloodstream, and it's smaller than a single skin cell. You're a hospital volunteer, 34 years old, otherwise healthy. You don't think about the cut again for the rest of your shift. 12 hours pass before it starts to matter. At hour 12, the skin around the cut turns faintly pink. You assume it's irritation. It's not. It's the opening move of your immune system, and also, without you knowing it yet, the opening move of the bacteria. White blood cells rush to the site, releasing chemical signals called cytokines, messengers that tell the rest of the body something is wrong here. Send help. In a normal infection, that's where the story ends. Redness, maybe some swelling, resolved in a few days. But this bacterium, likely a strain of Staphylococcus aureus, has slipped past the local defense and found a capillary wall. It's now traveling by hour 18. You feel tired in a way that doesn't match your day. You blame the shift, you go home, you sleep restlessly, and your temperature creeps up half a degree, then a full degree, while you're unconscious and unaware anything is tracking it. This is day 1, and your body doesn't know it yet, but it has already started making decisions it can't take back. Morning of day 2, you wake up with a headache and a low fever. 38.2 degrees Celsius, you take a paracetamol, you go back to work anyway because 100-degree fever doesn't feel like an emergency. Inside your bloodstream, the picture looks very different. The bacteria have multiplied past the point where local immune cells can contain them. They're releasing toxins directly into circulation now, and your immune system responds by flooding your blood with cytokines on a scale no longer local, no longer targeted. This is the shift from infection to sepsis. The moment your own immune response, meant to protect you, starts damaging the very tissue it's supposed to defend. Dr. Derek Angus, a critical care researcher who has spent decades studying this exact transition, has described sepsis as the body's response spiraling out of proportion to the threat that triggered it. Your organs don't yet know the enemy is small, they only know the alarm is loud. By hour 30 of day 2, you feel it. Your heart is beating faster than it should for someone sitting still past 100 beats a minute. You're breathing quicker too, without meaning to. Your skin feels clammy, despite the fever. This is your circulatory system trying to compensate. Small blood vessels are beginning to leak, a side effect of the same inflammatory chemicals meant to fight infection, and that leak drops your blood pressure just slightly. Your heart pumps harder to keep pressure up, you feel foggy, not sick exactly, wrong. A coworker notices you're pale and asks if you're okay. You say you're fine, you're not fine. This is one of the most dangerous properties of sepsis. For hours, sometimes longer, it can hide behind symptoms that feel like ordinary illness. Confusion arrives next, and it arrives quietly. Somewhere around hour 36, you find yourself rereading the same line of a patient chart 3 times without absorbing it. Your hands are cold even though your face is flushed. This mismatch, cold extremities with a hot core, is a sign your body is rerouting blood away from your skin and limbs to protect your heart, lungs, and brain. A defense mechanism called vasoconstriction in the periphery. It's triage, run automatically by your nervous system with no input from you at all. A senior nurse finally looks at you across the station and says you don't look right. She takes your pulse, she checks your temperature, 39.4 degrees Celsius. She asks when the fever started, and only then do you remember the paper cut 2 days ago and mention it almost as an afterthought. That offhand detail is the one that saves you. Blood is drawn immediately, lactate levels, a chemical marker that rises when tissues aren't getting enough oxygen, come back elevated. A red flag doctors are trained to treat as an emergency regardless of how a patient looks or feels. You're started on broad spectrum intravenous antibiotics within the hour, alongside fluids to support your dropping blood pressure. This window matters more than almost anything else in the entire timeline. Research led by physician Anand Kumar found that for every hour antibiotic treatment is delayed after the onset of septic shock. The odds of survival fall measurably by several percentage points per hour in his data. You were caught close to that window, not because a doctor examined you sooner, but because someone paused long enough to ask when the fever started. Over the next 6 hours, your temperature begins to fall as the antibiotics start clearing bacteria from your bloodstream. Your heart rate slows, the fog in your head lifts enough that you can answer questions clearly again. Your blood pressure, monitored constantly now, stabilizes with the help of the fluids. You're kept for observation for 2 more days, blood cultures rechecked, lactate rechecked, confirming the infection is retreating rather than advancing. You go home on day 5, tired, slightly bruised from the IV line, and profoundly unsettled by how ordinary the whole thing looked from the inside until it very suddenly wasn't. The Centers for Disease Control and Prevention estimates that sepsis contributes to at least 1.7 million adult hospitalizations in the United States each year, and that it plays a role in a significant share of all hospital deaths, many of them beginning from injuries as minor as yours. What makes sepsis so dangerous isn't its rarity. It's the reverse, it is common, it moves through the body using the same defenses that keep you alive every single day, and it can begin with an entry point too small to draw a second glance. Your body's response to a paper cut, a splinter, a scraped knee is not fundamentally different from what runs in the background of your immune system every day of your life, low level, largely invisible, mostly successful. What changed in your case wasn't your immune system malfunctioning. It was a numbers problem. A bacterium that reached the bloodstream and multiplied faster than local defenses could contain it, until a full body response was the only option left. Somewhere right now in your own bloodstream, your immune cells are running the exact same surveillance they ran for you in that hospital. Quietly, constantly, without asking your permission or your attention. Most of the time, that's all it ever takes.